My name is Ronnie Shure, and I volunteer as president of the board of directors for Healthcare for All Washington. The second Wednesday of each month, we have a educational program. Tonight, we'll be following up on Joe Biden's State of the Union address. Oops, I've already used that joke once tonight. Uh, but with a focus on the state of behavioral health care for youth here in Washington State. Max Lau from the Children's Alliance will address issues that we have here in our state. He won't be giving a State of the Union for the whole country, but after you hear him tonight, you may want to nominate him for office. So think about that. Max, be prepared. Thank all of you for joining us tonight. You too, like me, can volunteer for Healthcare for All Washington. Please consider coming to one of our policy committee meetings or communication committee meetings, or the third major committee is our fundraising outreach committee. In addition, we love having people give us their opinions and work on a specific project or just offer it. So I'm participating in this Zoom meeting from the lands of the Coast Salish peoples. Our efforts to achieve healthcare for all includes all the peoples of this land. Please take a minute to acknowledge the people in the lands where you are joining us from. We acknowledge all the ancestral homelands and the traditional territories of indigenous peoples who have been here since time immemorial. As we discuss behavioral health issues that we're focusing on with our youth today, we want to acknowledge role models that Native peoples have passed on to us. So it's not just taking care of the land, but taking care of the people as well. They've shown that there's ways to learn through their traditions, like learning through observing and then pitching in, getting youth involved in, all the activities. And of course, we also know storytelling is so important. The stigma of mental health issues, of thoughts about suicide, of substance use disorders are often hard to overcome. And when we look at youth, we know it's even harder. So storytelling is an important part and an important role that we learn from Indigenous peoples. So let me bring Max up uh, and uh, tell you a few things about him. He's the policy manager for health and economic justice with the Children's Alliance. We know in building healthcare that it takes more than just providing an insurance card. There are determinants of health and justice that are critical to ensuring that we have an equitable and fair healthcare system, or a true healthcare system. The Children's Alliance has been a strong ally in healthcare advocacy since the early days when we first started Healthcare as a Human Right Coalition. The Children's Alliance was there, and they've brought several legislative actions over the years, and Max will share the current actions. He's a local guy, born here in Seattle, and while I joke about nominating him for office, he has had dreams of being a leader in our community. He certainly had, childhood dreams, but he ended up finding a calling in mental health and social policy. He graduated from Western Washington University. He moved to Denver for graduate school, and then he got bit and by someone who got him involved. He worked for a state representative in Colorado before he returned to Washington to kind of share those policy actions or knowledge that he picked up. So with Children's Alliance, he tracks legislation, He does, research policy and monitors that, and he looks to the overall advocacy goals of the organization. So, Max, let me pull my face off the screen. Make sure that you can unmute. Looks like you're unmuted. So let's share your screen and get started. Thank you.
Thanks so much, Ronnie. It was a very gracious introduction. I appreciate that. Hey, everybody, glad to be here. It's really a privilege to talk to you guys tonight about something that I imagine we're all very passionate about. So I appreciate you dedicating some of your precious weekday evening time to talk about some really important issues. Like Ronnie said, I'm the Health and Economic Justice Policy Manager for the Children's Alliance, and have been focusing a lot recently on specifically youth behavioral health, which of course is an integral part of healthcare in a holistic way. So a little bit of background, so Ronnie touched on this. I have a bachelor's in psychology from Western Washington University, and then I moved to Colorado to do my master's in social work with a policy concentration there, and have always been very dedicated to mental health and behavioral health as a subject matter. And then a lot of my policy background got started working in the Colorado legislature, and then before that worked in immigrant and refugee affairs office for the city of Denver and did a lot of work with language access there as well, before moving back to Washington. So a quick overview of what I'm going to talk about tonight. I'll give you a quick background on the behavioral health crisis in Washington. A lot of the data I'm going to share is being pulled from a report that the Children's Alliance published last year, looking specifically at kind of the equity aspects of behavioral health care. And then I'll also touch very briefly on some previous legislation from 2023 and beyond and before, just to give you a little bit of context for some of the work that we were able to do this year. I'll go over the bills and the budget items that we were able to be successful in for 2024, and then talk a little bit about some of the opportunities for 2025 and beyond, and focus specifically on continued advocacy. And then as well, learning from what other states are doing to address the behavioral health crisis that is by no means isolated to Washington. It's a national, if not global, issue, but Washington certainly has opportunities to address some of those issues at home. So what is the state of behavioral health right now? Let me move these icons so I can actually see my slides. So by the numbers, over a majority of teens, so 58%, are experiencing at least one or more symptom of depression or anxiety. Breaking that down a little bit more, 1 in 5 teens need clinical care for a diagnosable depression or anxiety related disorder. And then 1 in 10 have reportedly attempted suicide in the last year. I'm sure I don't have to convince anybody that these are obviously unacceptable numbers, and this is not something that we should allow to continue by any means. And this should be a priority for us. And thankfully, it is a priority for the legislature. So we are able to get some pretty good progress in that area. The rate of symptoms have increased from 42% to 58% over the last 10 years or so. I will quick caveat, some of my data is ever so slightly out of date. The 2023 Healthy Youth Survey actually got released today. So I wasn't able to include the most up-to-date information, but I will say that we are looking good. The trajectory is positive, so there is some benefit being seen already from recent legislation. That being said, it's no doubt to anybody that leading up to the pandemic, and then especially during the COVID-19 pandemic, behavioral health is an increasingly present issue. And then kind of from an equity standpoint, the rates of depression and anxiety symptoms are the highest almost across the board for the kind of checkbox on the racial identity survey of more than one race. So this is inherently an issue of racial equity as much as it is health equity in general. And I'll touch on that a little bit more here in a second. Some more numbers for you. Among Washington adolescents, 28,000 are choosing not to seek care at all. This could be for a number of reasons: affordability, accessibility, cultural sensitivity, or just stigma against receiving mental health care in general. 35,000 are trying to seek care, but there aren't any providers available to them. 10,000 adolescents are trying to seek care, but just can't afford it. And then 31,000 adolescents are receiving care in some form, but it unfortunately does not meet evidence-based standards, which is another issue kind of across the board for behavioral health care. Altogether, we're seeing around 73,000, or just around 2/3 of Washington adolescents are not receiving any kind of behavioral health care for a clinically diagnosable depression or anxiety related issue. A term that I like to throw around a lot when discussing access to healthcare is care deserts. It's unfortunately a very easy habit when you are kind of in the Seattle, Tacoma area, these urban centers, to turn an unfortunate blind eye towards some of the issues that are specifically affecting rural communities. So when I say care deserts, that's primarily what I'm referring to. Rural areas, and even some areas in urban centers that have a need for behavioral health care but simply don't have any access to it. A lot of these areas, there's a reliance on few or sometimes even one provider for potentially thousands of people, which is obviously not appropriate. There's also a very high reliance on emergency rooms for behavioral health issues, which presents a number of issues further down the line. Behavioral health or emergency rooms typically have very limited beds, especially for psychiatric units. And then a lot of these ERs and emergency rooms don't have effective transition routes out of the ER. So you end up with a lot of people who go to the ER for a behavioral health crisis or a behavioral health issue because they have nowhere else to go, and then they kind of end up stuck there, which is not the best use of an ER. There are more appropriate avenues, they're just not available, and that's an issue that we need to address. Only 12% of Washington lives in an area where they can expect to receive care, which I think says a lot about how this is not specifically and not uniquely a rural issue. It's an issue across the entire state. I think it just presents much more visibly in rural areas. This map I've included here on the right shows specifically some of these counties in Eastern Washington that have a very alarming ratio of residents to mental health providers. And I think it's very clear in that sense that this is a rural issue, not exclusively, but especially. Rural areas typically also have a higher rate of reliance on things like Medicaid or Apple Care, or subsidized healthcare, subsidized health plans, which isn't inherently an issue, but there is a problem and a growing problem in behavioral healthcare with reimbursement rates and insurance plans covering behavioral healthcare. I will say, as somebody who has gone down that path initially of becoming a behavioral healthcare provider, and I have a lot of friends who are therapists and clinical workers, that there is a growing movement to challenge some of the insurance providers' mandates around behavioral healthcare, to the point that some people are choosing just not to accept insurance at all, because unfortunately the way that insurance companies enforce their reimbursement plans and their reimbursement processes puts providers in a tricky situation of having to inappropriately diagnose people in order to receive reimbursement, which is obviously not ideal. And I'm sure I don't have to convince anybody here that private insurance plans are not conducive to an equitable and accessible healthcare system by any means. And then also just having a delayed diagnosis, so especially for children, is extremely dangerous, right? There's a growing need for early intervention to catch these things early on, because not doing so can create a situation where children are developing lifelong struggles. So to highlight some equity issues specifically, nationally, so these are not exclusive to youth per se, but these are issues that you can see across the board, across the country. LGBTQIA folks are 2.5 times more likely to experience depression, anxiety, or substance use disorders. And then among them, transgender individuals are significantly more likely to attempt suicide. 11% of Black people are not insured, compared to 7% of white people. 27% of Black people are below the federal poverty limit, compared to 10% of white people. And then 1/3 of asylum seekers report experiencing depression, anxiety, or PTSD symptoms. And then among Indigenous youth, they are the highest for reporting feelings of being sad or hopelessness. So what I want to say here is that in order to address a health issue, you have to at the same time highlight the fact that racial inequity or oppression of marginalized groups is an inherent core problem and a core aspect of a broader health issue. And therefore, all solutions to that issue have to have some component that specifically tries to address these equity issues. Some of the barriers that we're seeing for these marginalized communities, there's a lack of workforce diversity. I went through my master's program for social work. It was, granted, it was in Denver, but it was also overwhelmingly white people. And not that that's inherently a problem, but what you have when you have a lack of diversity is you have less optimal outcomes for patients in a behavioral health setting. There's a considerable amount of research, and I'd be happy to share this with folks if they're interested, that when you're able to see providers who identify similarly to you, you have significantly improved health outcomes. And I think that is especially true for behavioral health. There's also language access issues. That's something that I care about very personally as someone who's worked with immigrants and refugees before. If you have therapy and your clinician and the patient don't have a common language or don't have good language skills to talk to each other, it's really limits the amount of care that someone's able to provide. You have a lack of insurance or underinsurance. There's a lot of negative stigma around behavioral health, and then difficulty navigating the quote unquote system. Again, I'm sure I'm preaching to the choir when I say that our current healthcare system is by no means equitable and easy to navigate. Even if you can speak English well and you don't have, if you're a neurotypical English speaker who has health insurance and everything, even then it's still incredibly difficult to navigate. So it's by no means an appropriate or effective system. So to touch on some recent bills, and I will say that this is actually my first, so the 2024 session was my first session in Washington. So I am somewhat familiar with these bills, but I wasn't here during their passage. So you have to forgive me. This is by no means an exhaustive list. But a number of these previous bills did have progress this year. So that's why I want to highlight some of them. The 988 crisis line, which was established in 2021, Washington ran a bill to create the Crisis Response Improvement Strategy Committee, or CRIS for short. They made a number of recommendations to improve that, one of those being the Collar Bill of Rights, which aims to incorporate lived experience in some of the procedures around responding to the crisis line. There was, as far as I'm aware, pretty limited movement on that this year, unfortunately. But there was a lot of progress in just incorporating lived experience in general, which is really good to see. Additionally, though, we did see in the most recent 2024 supplemental budget, there was $30 million appropriated to fund mobile response units to the 988 crisis line. Mobile units is kind of a recent push across the health board in general, especially addressing some of these quote unquote care deserts. The 23-hour crisis center, so that was created last year. At the time, it only served adults, so 18 plus. Which obviously presents an equity issue for minors who need crisis care. And then there was also a bill, HB 1724, which created the behavioral health care provider stipend program. It made some adjustments to licensure and supervision requirements and created some stipends for new behavioral health care providers who are still in that process of getting supervised hours to get licensed. And we're already seeing benefits. So like I mentioned previously, the health use survey for 2023 came out today. I wasn't able to comb through it super in detail, but a quick skim shows that we are seeing improvements based on some of these recent actions. So that's great to see. So to dive in a little bit into some of the 2024 budget and policy wins, this is by no means an exhaustive list, but I'll highlight a couple ones that Children's Alliance was especially involved in. These conditional scholarships. So I'm sure some of you are familiar with the Washington Health Corps, which I believe is under the umbrella of the Student Achievement Council. This creates scholarships for people who are in school to become some form of health provider. On the conditional aspect of that being that they commit to serving under-resourced or underserved communities. There was a bill this year to add behavioral health providers to that list. So new providers will be able to get scholarships on the condition that they commit to serving these communities. So this should address the provider shortage by removing some of the barriers to becoming a provider. And something that Children's Alliance and I'm especially excited for is promoting workforce diversity among behavioral health providers. Like I said previously, a more diverse workforce just means better outcomes for patients and clients across the board. And then in the most recent budget, they got $150,000, which is good to see, but it is not the full appropriation that was requested. So there's still an opportunity for continued advocacy there. Behavioral health providers. So this builds on the bill that I just mentioned. It continues to alter some of these supervision and licensing requirements to streamline that process. It strengthens the stipend program, and then there was also finally funded $288,000 in the budget. That was fully funded, so that's great to see. And then the 23-hour crisis centers, which were created last year, now are able to serve minors. Pretty straightforward bill, but it's great to see that equity issue that was able to be identified quickly and addressed. I think it shows a lot about the legislature's priorities as far as not only providing better and new behavioral health resources, but ensuring that they're equitable and accessible across the board. To highlight a few budget specific things, the Children and Youth Behavioral Health Work Group, which is a subset of the Healthcare Authority, they had an extended timeline. So that I want to say it's till 2029. Don't quote me on that, but it is extended a number of years. They got some more funding, and now there will be youth representation. So like I said, that there's a recent push for more lived experience in some of these policy decisions. Now the Youth Behavioral Health Work Group will have youth representation, which is great to see. There was $150,000 allocated for OSPI, the Office of the Superintendent of Public Instruction, to hire staff to support a development of behavioral health curriculum for public schools across Washington. I mentioned previously that one of the barriers we're seeing for youth accessing care is stigma. And I think having an inclusion of behavioral health information in the public school curriculum will hopefully address some of that. Definitely not a perfect solution, but great to see. Anyway, there's $400,000 for continuing the development of BH360, also known as Parent Portal. This is a digital dashboard for families to access behavioral health care information, information around navigating the system and accessing care. So again, just another step towards making care accessible. I think you'll be able to see trends among a lot of these bills and budget items that are about either addressing the accessibility of care, the affordability of care, or the quality of the care. And then there was also $5 million for what are abbreviated as CCBHCs, or Certified Community Behavioral Health Clinics. Those were previously receiving a lot of federal funding. This will be bridge funding for the state once those federal funds dry up, continue to be funded and expanded upon, so that we can embed behavioral health services directly into the communities. So that was a pretty short list. There was a lot more bills. I'd be happy to talk about some of the other ones with anybody who wants to reach out. But I want to focus now on some of the opportunities that we'll have in 2025 and beyond. Like I said, a lot of these bills require some of that continued advocacy. Many large scale policy solutions require years and years and years of pushing bills. I'm sure nobody here is new to that concept. A lot of times you have to run a bill many, many times in a row before you can get success. So some of the things that we're looking forward to, like I said, 1946, that's the conditional scholarships for behavioral health providers. That was only partially funded. So something that we want to push for is continuing that investment in workforce development. I would love to see that program be fully funded and even expanded to include more people. Grant funding for school-based behavioral health services. So this was a bill that unfortunately died this year, but it would have created a school-based behavioral health statewide network administered through educational service districts to embed some of these behavioral health services, screening services and clinical services directly in schools. And it would also include funding, grant funding for these school districts to develop their own behavioral health crisis response plans. I think it's really important as we see that healthcare and behavioral health disparities are oftentimes unique depending on what part of the state you're in, what area you're in, that those local governing bodies like school boards or school districts are able to create unique solutions to address their problems. Many issues are obviously statewide, but as much as possible, I think it's best for communities to create their own solutions. People generally know what they need and they know what's best for them. So having community embedded behavioral health services is generally good, I would say, with statewide support and coordination as well. And then some broad anti-poverty measures. There's also a considerable amount of research that goes to suggest that poverty and economic instability can be a significant predictor of developing behavioral health problems, especially among children. So in that sense, any anti-poverty legislation is also indirectly going to be behavioral health legislation as well. So progressive revenue to fund these programs, direct cash benefits to address poverty and to address economic instability, and then economic justice just broadly across the board goes hand in hand with behavioral health policy. Some specific opportunities. So like I said, the school-based behavioral health network, that bill didn't see any movement this year. Hopefully we'll be able to see some movement next year. And then drawing on a solution from Colorado or from other states. I did a lot of work in Colorado, so it's just what I'm familiar with. And I got to work on this program, which was I was super excited about. There's a program in Colorado called iMatter. The short summary of the program is that it provides free screenings in schools to students to identify people who might be good candidates for behavioral health intervention. And then it provides 6 free sessions of therapy to students, all minors in the state, regardless of insurance coverage or, if you're undocumented or if you're, or anything, like anybody can access it. So that's phenomenal. And then another aspect of that is really interesting to me, and I don't know if all of these would be directly transferable to Washington necessarily, but they also implemented a new therapy age of consent of 12, so that anybody 12 or over is able to access these clinical interventions or these sessions with or without the consent of their parents. And I think the idea behind that is, obviously, in an ideal world, families as a whole would be involved in the behavioral health process. But the unfortunate reality is that occasionally some students and some children and youth need behavioral health care because of their family environment. And so having an avenue for which they can receive care is, I think, a good thing. Universal health coverage, definitely preaching to the choir on this one. I'm sure I don't have to convince anybody here that this would be a good policy, but including behavioral health in that coverage, I think, would be a crucial step. Behavioral health goes hand in hand with physical health care, and so I think having broad coverage across the board to address those issues would be a good step in the right direction. Like I said earlier as well, early intervention, coverage for early intervention services, and continuity of care. So this might look like a number of things. There was some progress this year on a program called Holding Hope, which is mental health consultants for infants and early childhood healthcare, or early learning and childcare providers. Part of that being an effort to try and identify issues early on, so that we can connect children with services or with supports as early as possible to prevent some of these behavioral health issues developing into lifelong struggles. And then continuity of care. A lot of young people kind of in the 0 to 6 age range tend to get kind of bounced around between coverage plans, which can be really disruptive to their care. And, especially as their parents, their income changes, it can change how they qualify for certain things. It's super messy right now. So promoting continuity of care so that young people in that really vulnerable period don't have a drop in their coverage, I think would also be really important. And then accessibility, just broadly speaking. Like I said, I have a background working with immigrants and refugees. I've spoken with a number of people this year in meeting with legislators who have told stories about how migrant children, especially who have either limited English speaking abilities or come from families with limited language abilities, may be aware that they need behavioral health care and may make an effort to try and receive it, but ultimately are unsuccessful because a lot of the care services are so inaccessible to people who don't speak English or are undocumented. So promoting accessibility in that is especially important. Having care that is culturally aware, this ties into some of that diversity component I was talking about earlier. It improves outcomes. Having therapy is great, but if you're meeting with a therapist who is completely unfamiliar with your cultural background, it's not going to be optimal for you. And that ties in especially to something that Ronnie was touching on earlier this evening about incorporating indigenous communities or tribal communities. Their behavioral healthcare needs are going to be different than people who don't live on tribes or on reservations. So having culturally sensitive care, culturally aware care is really important. And then finally, community integration. Like I said, the certified community behavioral health centers or clinics, I think that's a really good model for implementing care embedded into a community as opposed to having these kind of hub resources. It does a lot to address this care deserts I touched upon earlier. A big barrier for people, especially in rural communities, to accessing care is the fact that they may have to drive hundreds of miles to get care. And for behavioral healthcare, especially, a lot of times you need frequent, regular sessions over a long period of time. So having a significant barrier like distance can be really damaging in that sense. And then just a few stepping stones I think that we need to touch on in order to get to kind of a more ideal behavioral healthcare environment. Increasing state revenue, funding for these programs, right? If we want to provide subsidized or free behavioral health care to people, we need to pay for it. And I'm sure everybody here is familiar that whenever you propose a new program or a new bill in the legislature, the first question everybody always asks is how are you going to pay for it? So increasing state revenue, having a progressive tax code to reduce some of that economic burden on working class people. Like I said, poverty is a significant predictor for behavioral health issues. So I think reducing that burden as much as possible would be great. Washington, of course, has a very regressive tax code. It used to be worse in the country. I think now we're the second worst in the country. So we're getting there, but very slowly. Workforce development. There's no point in free therapy if there's no providers. We need more providers. We need diverse providers. And we need those providers to be providing evidence-based care. And then having a long-term investment. We need to maintain this momentum over many years. Like I said, a lot of this policy, ambitious policy, requires continued advocacy over many years. We can't just pass a couple of bills, wipe our hands and say we're done and we've solved the issue. This needs to be a continued process over many years, and we need to make sure that we aren't taking steps backwards. People are always going to introduce bills to either redirect funding or reduce funding to programs. Ensuring that doesn't happen is going to be a crucial component of that continued advocacy, and making sure that when we do create new programs that we aren't inadvertently, getting in the way or creating barriers somewhere else. And I think that concludes the bulk of my presentation. There's my email address if anybody wants to reach out. This was by no means an exhaustive presentation on behavioral healthcare, but I'd be more than happy to talk with people or to connect them with resources. Like Ronnie had said earlier, please feel free to reach out if we aren't able to get to everyone's questions. I would love to chat.
Well, thanks, Max. Thanks for identifying those issues and giving us some steps to move forward. If you could stop your screen sharing. I don't think I have that power. There you go. So thanks for sharing that information, and please add questions into the chat. We will be coordinating that, and Cello will join us shortly. So I'm going to take you out of the screen for a few minutes, but don't go away, Max. We're going to bring you back, okay? And so if you can look into the chat, you will find space to enter questions, and I hope you will take that opportunity tonight. But right now, let me introduce Peter Lucas, our treasurer, and Peter is going to tell you how easy it is to support us and how easy it is to donate.
Well, thank you, Ronnie, and thank you, Max, for alerting us to the youth mental health crisis. And it's really hits home for me. I'm a practicing telepsychiatrist, and I commonly deal with some of the situations you described, such as treating patients who are stuck in the ERs for long periods. And I'll just interject our first question for when the Q&A session comes is, how do you think telemedicine can address some of these care deserts? How can we provide services to people where they are, so they don't have to drive long distances? But getting back to the pitch, over the last few years, our organization has chalked up many legislative victories in Olympia. We were very active in the latest session, which just ended, and many of the progressive bills that we supported and lobbied for were passed. And for those of you who want an update on our accomplishments, click on the legislation tab on our website. Now, to maintain our momentum, it's vitally important that we meet with our legislators, grow our membership, educate the public, and mobilize our supporters to spread the word about universal health care to their families, friends, and most importantly, those in power in Olympia. And the way we go about achieving those goals is largely through the hard work of our lobbyist, Lonnie Johns Brown, who is very active all year round, but especially during the session. In addition, we employ a communications specialist and are active on social media, conduct monthly webinars such as tonight's presentation, and have meetings with civic groups and host other events. Financial support of those two staff members, as well as our other activities and obligations, all require money, which is why we're asking you to donate tonight. So as Ronnie said earlier, our goal tonight is $250. Please go to the links in the chat or on our website and click on the donate button. And you can make a one-time donation, but we would especially appreciate it if you could make monthly recurring donations. So please donate so we can spread the word and bring about universal, publicly financed healthcare in Washington. We're making real progress, but there's still much to be done, and you can help. Thank you.
Thank you, Peter. So remember to go to the chat and add your messages, questions, but also you will see the donate button or the link to our website. If you are able, please make a donation before you leave us tonight. If you are interested in volunteering, click on the icon that says Get Involved. Please take some time to do that. I'd like to bring up one of our board members, Cello Echeverria, and bring Max back up, and we'll jump into the Q&A. Cello, if you want to unmute yourself.
Yep. Can everybody hear me?
Yes.
Okay, perfect. So Max, actually, you can read the first one yourself, which was, as Peter said, and Peter himself is a practicing psychiatrist. How much has telemedicine done to water the treatment desert to date, and what more can be done in that regard?
Yeah, so I mean, I think that telehealth has definitely been one of the positives, one of the really big significant changes we've seen coming out of the pandemic, the fact that it's become so available. In Colorado, when I was working on that program that I mentioned, the iMatter program, I want to say the vast majority of that care is offered virtually, and has been received really well by the people who've attended that. So I think telehealth as a solution is really good. And is a huge step in kind of promoting accessibility of behavioral health care. But I think it does also present a number of unique obstacles that maybe aren't as present in kind of the in-person traditional health model. That being some equity and some access issues with things like technology or internet access. We're getting better, right? You saw like tonight with the closed captions on Zoom and things like that. There is a lot of steps towards promoting more accessible digital communication. But I think there are still steps we could take to improve that. But definitely telehealth has been a huge step in the right direction. having more providers who offer telehealth care is super good for, especially like I said, those care deserts, those rural communities who may have to drive significant distances. Telehealth is great. Super happy that it's been expanding so much recently. We just have to make sure that we are addressing some of those unique barriers that are present, especially in the digital landscape.
I have a follow-on question for that. What has your experience been in terms of telehealth with people with limited bandwidth, that don't have broadband or have limited minutes on their phone plan to access?
Yeah, I mean, it is tricky. So I don't have a ton of experience dialoguing or talking with telehealth providers necessarily about some of the unique issues that they're facing, or some of the solutions they may be trying to implement to address that. I think it really does highlight some equity issues around people like working class people or people with lower incomes who might have things like data caps, right? And I think it highlights the importance of having community embedded behavioral health resources, so that if you do have barriers to accessing digital care or telehealth, that there is still somewhere for you to go. There has been some recent policy in other states to try and address that with certain kind of combining telehealth with a somewhat in-person model. So in Colorado, I'm going to refer to Colorado a lot just because that's what I have a lot of experience with, but they've started blending some of that telehealth and in-person care for pharmaceutical services, where if you don't have access to a pharmacy, there are still locations you can go to pick up medications from what is essentially a vending machine, but have an option there, an opportunity there to interface virtually with an actual like live in-person pharmacist to talk about that medication. So I think having some, replicating that in some way where people who might not have, great internet access or something along those lines can still access health or behavioral health care, replicating that in some way. I'm not sure how that would happen necessarily. I'm sure that would present its own unique host of issues, but there are opportunities there.
Thank you. David Loud asks, can you share a little bit more about your experience working with refugee and immigrants?
Yeah, so I was at the City of Denver's Office of Immigrant and Refugee Affairs. And I think one of the things that stood out to me when I was working there, especially doing behavioral health policy now, is how difficult that, like I said, that system is to navigate and to access. One of the projects I worked on when I was there, and it took me almost an entire year to do, we were creating a city guide for immigrants and refugees that was essentially a really short like booklet with half-page summaries and guides on specifically how to access and navigate local and state services and resources. And a lot of that was informed by going to communities that had high immigrant refugee populations, and talking with them in person to person, and saying, what do you need? This was in 2020, 2021, so kind of right at the height of the pandemic. And so that was top of mind for a lot of people. And a lot of them wanted access to things like stimulus care, stimulus packages, additional behavioral health services and telehealth care, but had a really hard time accessing that because that system is so difficult to navigate. And especially so if you have limited English speaking capabilities. So, in crafting behavioral health policy, I think it's really important to not only make sure that it's a robust, system or program that is well funded and accessible and whatnot, but also that it's easy to use. That difficulty in accessing care is a huge turnoff for a lot of people who might say, it's the first step in that care journey for a lot of people is just recognizing that they want to get help in the first place, and then taking that step into reaching out is so difficult for so many people that when you make that step needlessly difficult to navigate and all these hoops you have to jump through, it turns a lot of people away from care that they deserve. So promoting accessibility in that sense, I think, is also really important.
And following on the accessibility pathway, Ronnie asked, education in our schools about behavioral health issue was not approved by the state legislature this year. It doesn't make sense to me, but they're very strong opponents in education. What can be done to education? What can be done to educate youth outside of our school system? Ronnie, you meant to provide behavioral health. Yeah. So what can be done to provide behavioral health to youth outside of the school system, since it wasn't funded in the 2024 year?
Yeah, so it is really difficult. I talked a lot about how important it is to allow these kind of local governing bodies to develop their own behavioral health plans, but that does also present an issue where some localities are maybe not providing the most equitable care to their constituents. And you see that a lot in kind of the local education space, unfortunately. I think as far as providing education outside of the school, it becomes really difficult, just because schools are really the most effective and easiest way to get contact with youth across the state. I think different virtual services. So, like I said, BH360 is a new thing they're developing to have a accessible, easy to navigate virtual database for these behavioral health services could be a really good step in the right direction. And then also ensuring that we target every single kind of contact point that youth have to provide these services. So schools obviously is kind of the top of mind for a lot of people right now, but making those services available in other aspects of children's lives too. In childcare is another one that people are focusing on right now. Having a really not only accessible system in schools, but having a diverse set of entryways into behavioral health care could definitely help with circumnavigating some of the limitations that schools provide.
In that, I actually have a follow-up question for that. Has the Children Alliance personally, or are you aware of utilizing the community health boards for that outreach?
I'm not personally aware. So like I said, this is my first session in Washington, so I'm still getting caught up to speed with some of the specifics. That's something I'd definitely like to follow up on that a little bit. But there has been a push, certainly, that at least I've seen recently in conversations with legislators to try and strengthen some of the more localized community-based behavioral health connections or entryways to behavioral health care. So yeah, I'm not super familiar with that specifically, but I'll definitely look into that.
And Case asks, tell us more about behavioral health clinics you mentioned. Does this include clinics that are in community health centers like CMAR?
So I'm not familiar with how CMAR would be classified specifically. The funding is very specific in its language. It's for certified community behavioral health clinics that were receiving funding already from a federal grant program. I was at a conference earlier this year for the State of Reform Conference for Healthcare, and they talked a little bit there about how this model of this community behavioral health clinics is not all encompassing and does exclude a lot of community behavioral health clinics and providers. So I don't know specifically. I do think they're trying to expand that, and that is part of what the $5 million in funding is supposed to do, is to help them transition off of federal funding onto state funding, and then hopefully that will allow them to expand to more centers and more clinics. About CMAR specifically, I'm not sure.
Okay. And David McClanahan asks, how does a new provider just getting a license take clients find job opportunities in Washington State?
Yeah, so that's a tricky one. For most of my college and grad school journey, that was my intention, was to become a behavioral health provider, and a lot of what turned me off of that and pushed me into the policy space was because that process was so difficult. So I'm very familiar with how daunting it is to get all the license get all the supervised hours in order to get licensed, and how many financial barriers there are to that. There are recent bills to try and improve that process. So one of them recently, HB 2247, which was a recommendation by the Children and Youth Behavioral Health Work Group, creates new professions for people in that transition period out of education and into the workforce. I believe they're called psychological associates, or mental health associates or something along those lines. I don't remember the exact wording, but it does allow for new providers to start seeing patients and start practicing before they've completed all those requirements to get licensed, under some pretty specific supervision requirements, of course. Specifically, like how would you get involved in that process? I'm not totally sure because it's relatively new. It's something that I'm going to follow closely as they start going through the rulemaking process for that. But that is something that the state is trying to address. I think their ultimate goal is to ensure that when they pass new legislation to do things like improve the workforce or diversify the workforce, that those changes can take effect sooner, as people are able to enter the workforce quickly, and to streamline that process in general. So yeah, specifically, I'm not totally sure, but that is something that the legislature is trying to address for sure.
And I think we have a final question. We still have, oh no, we've got lots of time. We're good. Alicia asks, I just learned that Seattle School District decision to close the alternative high schools that serve teens with behavioral challenges. Are you aware of this, and what can be done to challenge this effectively?
Yeah, so I wasn't aware of that specifically. I'm still working on getting familiar with some of the local policy work that's being done to address behavioral health. But I will use that kind of to tie into some of the things I mentioned about economic justice. Schools especially rely on a lot of state funding for opening schools. And so I know that the Seattle School Board especially is facing a lot of trouble right now with their funding, and being forced to close schools, which sucks. And it really goes to show how important it is that we protect funding sources for schools so that we don't have to close schools. Having schools and school models available to address some of these unique populations or the unique needs of specific populations, I think is really important. It's a kind of a core component of this holistic behavioral health approach. My recommendation as far as advocating for the protection of schools who serve these communities would probably be to focus on economic issues and progressive revenue, because we need that funding available. In 2024 being a supplemental year, there was a lot of conversations around what is the best use for funds. How do we best spend money? And so you have a lot of really good programs and really well-intentioned programs that are unfortunately competing for the same dollars. And that problem only exists because we allow it to exist. Because we don't have a tax system that taxes, the highest earners and the top, percentile of wealth in the state. And so there are a lot of dollars going untaxed that could be funding things like school construction or maintaining schools so they don't have to close. So yeah, specifically, I would probably just say, pay a lot of attention to the intersection of behavioral health and economic policy. They're very closely linked, especially with education.
Well, thank you, Cello. And thank you so much, Max, for sharing that information with us. Thanks for joining us late at night on a weeknight, and to address a lot of those issues. We know that it's passing a bill is not the final step. Implementation to ensure that services are being provided, to ensure that all clinics are able to develop these new services, and the comment about CMAR qualifying for certain, or being a qualified health center, do they qualify for these new behavioral health clinics? So it's work that all of us need to be involved in. There are clear things that we can do in the legislature. There are looking or, social justice issues such as the looking at the social determinants of health, but we also need to look at the political determinants of health. And that's a lot of the work that we are trying to participate in, and that Children's Alliance really holds up a very strong banner to guide us and to lead us into those issues. Behavioral health issues are not going away. They are they come with a stigma, a lack of knowledge. Education and political action are going to be some key steps to make sure that we move forward and address these issues. So thanks again, Max, for sharing that information, for taking your time, and for all the work you're doing for our community. Thanks for helping lead us. I'd also like to thank the volunteers that are facilitating this event. Cello Echeverria for asking those questions and helping guide that. Rich Legou and D.W. Clark and John Britt for handling the background in Zoom and making sure that all of these things are happening. And our communications committee and our fundraising committee and our political action committee are really key issues in moving all of this work forward. So please join us, if you are interested in helping the people in the background make this happen. Most of all, I want to thank each of you for joining us tonight, for taking your time and adding to our work. It wouldn't be happening without your support. So thank you. Thank you. And finally, join us on the second Wednesday next month, April 10th. We will address behavioral issues in adults. Jim Hoffenbeck from the Downtown Emergency Service Center has been helping me coordinate some speakers or a program for that night. So please join us on April 10th. And I have a homework assignment, which is to read Congressman Adam Smith's personal journey. He shares his view of the limitations of our behavioral health system. And while Congressman Smith won't be a speaker, he has written a book called Lost and Broken. So check that out. He has provided several interviews in that process. So Congressman Adam Smith will be our poster child for, or poster adult for our discussion next month. So again, thank you all for joining us tonight. And thank you, Max, for putting all this together. Thank you. Thank you.